To conclude this conference, I'd like to call the stage Ole Norheim and Trygve Ortusen and Tessa Tentoris and Rita Sedana from WHO's UC ethics team.
I think we should have all in the team, so including you and Toby and Axel.
Should we?
Yes.
All right.
Yeah.
You're not expecting us all to speak, right?
You didn't prepare anything? Most of them.
Have I forgotten someone?
So, first of all, piece of good news.
No.
Piece of good news, the lockdown has been lifted. The tea is starting up, so the siege is over. We can pretend that guy doesn't exist. No. No. Yeah. Turns out he never existed in the first place. Gita, are you here? Yeah. Oh, there you are. Hiding in plain sight. Thought we wouldn't see you. Thank you for staying as long as you have. And we're going to make this very short because we're as tired as you are. What made this meeting possible, besides the usual resources we can draw on for our annual conference, was the fact that WHO has asked a group of people to produce a guidance document on the kinds of things we're talking about here at the conference. And the sources of support for that project, some of which are Norwegian, were gracious enough to contemplate the possibility that not all of the meetings had to be in Norway, especially in the winter. And so we decided that one of the meetings should be here, and then all we had to do was to decide it would be the 2 days following our annual meeting, and then we could invite a lot of the people who would be coming here anyway for this consultation group to be speakers. And so it's all worked out extremely well. And we also got the great benefit of your wisdom in the comments and in some of the talks, which will enlighten the work that we do in the next 2 days as we continue our work on that project. So everyone you see in front of you is been taking part in this effort, and it's been a great learning experience for us. We hope that we'll pay WHO back by offering something useful. And I guess we're going to turn to Ulla first to outline some elements of not the process, but the product, I suppose. And then maybe we'll have more general discussion if people have something else they'd like to say.
Yeah, I'll not give a summary of the guidelines. What I would like you to do, just to invite you, now you have the opportunity to ask questions or give some advice. What would you like to see from this kind of guidance documents? What would be useful for you, or what would you as ethicists or economists or whatever recommend that we especially focus on after what we have learned these 2 days?
Despite Norm's talking about social determinants and their importance and several others as well, I still have a concern that this project is principally focused on medical care, and therefore will divert attention from various things that one could do about the social determinants of health, and as a result, not have the degree of improvement of health that one might have with further focus on the social determinants. So how could this, I'm not convinced entirely of what you said, but so how could this project try to reduce the degree to which, the focus turns to medical care and forgets about, at least to a significant extent, other things that have such an impact on health?
Not yet. Okay. More comments? Yes. Okay.
The guidelines. Who is it for? I think we should always ask that question. For us, it's probably the Minister of Health in his role as invested in him the the responsibility or the mandate to provide governance in the health sector. And how can we best guide him? And I think that's the question, or the document is really intended for this particular person. So keep him in mind together with the country which will probably use this. This is not going to be used by high income or high middle income countries, okay? So it's quite a specific product that we're looking for. And so always the question in my mind, like this afternoon, was, okay, how can I use this? I'm jet lagged, how can I use this? But that's always the question which is going into my mind. How can we use it to inform or to provide guidance to this specific person or the staff around him?
Dave.
Well, I hesitate to speak because my position is fairly obvious, I hope. If it isn't pretty clear what I'm going to say from what I said this morning, I didn't express myself very clearly. But it's obviously worry not just what the situation is going to look like when you achieve the objective, but worry about the situation from now, every stage along the objective, and who's benefiting and who's benefiting what, and how these issues are played out, the balance between priorities, these different dimensions of the queue, not just at the end, but every step along the way.
Can I just comment on that? The working title of the guidelines are a fair path towards universal coverage. So hopefully we hope to capture
Preaching to
that.
the converted.
So this is maybe also more for the background, but and it may partly be ignorance too about the exact purpose of the guidelines. But one thing that just struck me is to draw attention a little more to the wider context, not just the social determinants of health, but also senses of corporate social responsibility. Because it's one thing that we're saying, well, we need to deal with scarcity and prices that we're dealing with for drugs are what they are because they can't be any lower. But then if you're thinking of cases like antiretrovirals in South Africa, etc., GSK discovered their corporate social responsibility only after a lot of pressure happened, and all of a sudden a situation that was one of great ethical tension wasn't that much of an issue anymore. Or if you think of the case of Avastin and Zaltrab recently with Memorial Sloan Kettering here, where a single hospital system said, we're not paying for this drug that costs twice as much anymore, and all of a sudden the manufacturer reduced their costs by half, right? I mean, there are lots of other ways where some of these issues that we're rightly dealing with and that we'll never go away with can also be addressed, that I think will also matter for ministers of health to use other levers to at least lessen some of the tension. It will never reduce a lot of the really hard problems we're talking with, but it seems to be part of the broader picture that could be addressed some way. I think it's more for the background, but I also don't think it's completely irrelevant. So with those caveats.
Thank you, Adam. Alex?
So that point was partly what I wanted to say. So I think that's at least a few lines in the guidelines about the issue that resource constraints shouldn't be taken as exogenous, right? How much something costs, especially for a country like India, as we've seen in recent decisions, can be partly up to the country. And its stance internationally and its stance vis-a-vis its donors, etc., and in international negotiations. So I think even for a low to middle income country decision maker, you worked quite laudably within the idea that the budget, here we have a budget and this is what these things cost. Of course, as we've seen, these things are partly endogenous. The other thing was was something I wish Julio Frank could stay here a bit longer. We've discussed cost effectiveness and equity as two criteria, and I think they're very important, and the outline beautifully discusses them both, and financial protection. But he mentioned very briefly in passing, he said, we also considered, including the social meaning of various services. I wish we'd had him here to ask what he meant by this, right? But that, at least mentioning, perhaps a few, one doesn't just want a laundry list, but perhaps the Mexican example may serve the panel. What's involved here, and also especially services that aren't easily translated into cost per quality. For example, palliative care for those who are dying, right? Not many qualities to be gained there by hypothesis, but it's a matter of respect, and I think even in the human rights talk you briefly mentioned, it's regarded as cruel and unusual or something like that. Cruel and inhuman, yes. Absence of palliative care. Now that we all know that doesn't easily fit in a quality framework. So perhaps a few of these issues, and perhaps some of the members of the audience who have experience in Thailand, for example, might be interested in sharing with us what they think is missing from the already, we all agree with the importance of, I think, cost effectiveness and equity, but at least could be articulated maybe with one or two case studies.
The last 2 days, I think, there are such brilliant minds here, and a lot of commitment. So my expectation is high. So if I were to say what is needed, and Tessa, to answer your question, because I've spent a lot of time, had the privilege of sitting not just in federal with the ministers, but actually at the local government level where primary health care happens or doesn't in most cases. It has to do more than what the Cube is requiring, the trade-offs. And I think, Professor Sen, the questions and the issues that you raised, in fact, the risks now, as India and China go straight into what UHC, it's even more, its stakes are higher. So it's sort of, I am not convinced, or I am not seeing, I want this, what you do, to have relevance and use to countries like India who are trying to get universal health coverage, right? Because if India can do it, then some of the other developing countries stand a chance. But at this point, and I think, Professor Sen, you made the comment that it's not just about the different pathways, because what's happening now, we choose a pathway, and that means another one, that something is closed. So that means the risk is high. And so I think ethics offers an incredible, powerful lens to help and to enable decision makers to choose the pathway that does provide access to health.
Thank you.
Okay. My name is Musa from the National Institute for Research in Public Health. Of course, I'll be involved in today's discussion on the workshop, but maybe I want only to focus on this practical issue of these guidelines in discussing with the Minister of Health how to implement. So it should be really very clear that it can be used for each country. And if you take the countries, it depends the variation within the countries. Within each country, you have also variations, also in terms of different contexts. That's why the aspect of human rights and social justice should be really very developed in the context of gender issue, which has been not very much discussed here. But some of the things in universal coverage can be affected mostly by the gender issue in developing countries, because some of the ethnic groups are excluded, or they exclude themselves because of their behavior or because of their perception on the health interventions, and also because of the social structures. The women are not always leadership for going to the health centers. If they go to the health centers, they have to ask permission from so these are some of the things we need really to focus on, because the universal coverage can be there, but the application could be really questionable in terms of some of these exclusions. So I want just to tackle that. Maybe we can discuss more on that for the next 2 days. Thank you very much.
Thank you. Yeah. That's important.
Me again, sorry.
That's fine.
I've come back to take revenge on Norm, I thought. So the reason is that about 2 years ago, we had this little discussion about accountability for reasonableness and the role of public engagement. And he said, so what's actually happening in the UK and in Germany, all these places you've been? So I had to start on this big research project, which was only just published beginning of this year. Since everybody's advertising their own work here, I thought I could do that. But it took me a long time. At the same time, it was really interesting because it tried to look at the role of public engagement in health technology assessment and research allocation. And we looked at, with my colleague Julia Kreis, at experiences in Germany, France, and England. And it seems things are all over the place. And it came up a couple of times during the meeting here too, that a lot of people said we need more public engagement, but why exactly that should be, I don't think is always that well articulated. At the same time, there's this great vision that simply just engaging the public will make things better. So that's why my revenge is that I think Norm should explain in your guidance document what the right role of public engagement is in health technology assessment and research allocation. And the other thing that I wanted to also say, maybe also just to, because it's my little pet animal, but personal responsibility, I guess, is something else that would be worth thinking about. It's one thing to say we have a system of universal coverage, but if you don't meet certain health standards, if you're obese, if you're smoking, your premiums will be a lot higher, or we will not insure you. And with rising levels of obesity, not only in this country and in many other Western countries, I think it could be timely too to say something about that. So what's the role of public engagement would be, I think, useful to say something about. And what's the role of personal responsibility? As we know, Dan has things to say about that.
Thank you.
You're only supposed to assign tasks to others when they're not there.
You keep going.
Yes, two things. I came to this conference to learn because I do research, but I really don't do research in developing countries, so I thought I would come to learn. And what I discovered was that I do a lot of work, actually, the access to healthcare in developed countries. And my data set are usually rich and from rich countries. And over the 2 days, I'm just amazed at how many issues are actually the same in different language. So I think probably there are two lessons. One is that one request is we talked about maybe we want to monitor how the universal health coverage goes. And then in there, that measurement, just because literature is in the developed countries, it's not relevant. That's not true. I think there are a lot to learn from there. So that's one thing. And the another is that in developed country access to healthcare literature, all countries but United States has the universal coverage. But we still talk about equity. And we talk about how to measure need, what is the capacity to benefit, how to incorporate that. And then still there's equity and we worry about it and we keep measuring. So there are a lot of things that maybe this is a future project. And I'm thinking about what I know in that literature also, this is my second point, that many people alluded, there are probably many different pathways. There's no only one better way. And historically, all the countries are different. No country starts from scratch. So that means that there are many different things. And then I think as this effort rolls to different countries, it might be useful in a guideline. You think about what kind of key issues you want to document as the country start to have some achievement or failure. And then over the years, that become a data bank. And of course, we cannot have any causal relationship, but at least, well, they're private sector, but then this country had this regulation, seems to be there some patterns. Or this kind of private involvement that seem to work, but always it doesn't seem to go well, or something like that. And then that might be good, but in the guideline level, maybe there's some key aspect that you want the country to report. That might create some interesting experiment later. Thank you.
Just a comment on that. Thank you very much. And perhaps just give a little bit of insight prior to what Tessa mentioned on who the target is for the guidelines. As you know, the World Health Report 2010 was about financing the path to universal coverage. And I think there's 5 main chapters. One of them is on efficiency. And in a sense, this project was born out of the idea that first we thought, well, this was an opportunity to write the chapter that wasn't in the book on equity. So initially, we were thinking we'll write a chapter and it would be part then of a sequel to the report. But what became pretty obvious is we didn't need a chapter, but actually a tool that could be used in a much more practical way. And so that's sort of the background on where this piece actually has come from. And I think the idea of having some part of monitoring is in the guidelines, but I think that's something we're going to be discussing much more clearly, so countries could have some indication of how would they know if the situation by what they're doing is stagnating, it's getting better, or even potentially getting worse.
Okay, thank you. Many things were said, and we are still in the process, and we can raise other things also in the future. But what I'd like to bring to your attention is to whom does this guideline really is important. I would like to bring to your attention that it's not only the Ministry of Health. One of the things we have felt from the Health for All Almaty Declaration to universal coverage, which is similar also, is that we have failed to really implement the intersectoral collaboration. And the social determinants of health can never be addressed by Ministry of Health alone. The other important ministries, we have seen that in our countries, how we have really failed to work together, working together across the ministries. Even the example I mentioned in the morning, the family life education, the UN endeavor failed because we failed to do intersectoral collaboration was not really addressed well. That's why we failed. So can this guideline really address this issue and really show the countries how to do intersectoral collaboration so that we are effective? Thank you.
So one more, 2 more, and then, okay.
Hi, my name is Ann Kim. I really appreciate the whole conference thus far, at least the parts that I've been able to attend. But I really want to emphasize a part of her point here about the need for the infrastructure to also be addressed, and without considering it mission creep, perhaps to incorporate the need to look at whether there's good energy infrastructure or other things that are critical to be ensuring maternal mortality rates don't continue to rise, and other things along those lines. And I'd also like to piggyback on Dean Frank, as well as Alex, and a couple of other people also alluded to this, the point of the importance of certain things in certain social contexts, especially because, let's say in Mexico, something like a traditional lending circle very much emphasizes the cultural importance of having small communities that work together, and working with that social richness that already exists to ensure that health is further promoted, and those sorts of priorities that are created, nudging in that sort of direction. Thank you.
Okay.
Thank you. First of all, thank you for this great conference. I'm really satisfied from all these issues we're discussing. No, but I have a question. Usually, guidelines applies to set certain common principles. But in that case,
how country-specific approaches would be expected, reflected in this document, I'd like to know. Another issue I'm interested in is how market competition could be addressed to universal healthcare coverage, because certain countries have focus on competitive market, and then they apply to set universal healthcare coverage. So how they can be compatible together? That's the question. The process of the implementation of universal health coverage is often followed by the question, make people to shop to achieve the most cost-effective system. That's sometimes the question when decision makers cannot really address directly, make people shop or provide universal health care coverage and directly address the services they need. Thank you.
Okay, thank you. Rita, would you like to comment on that, or we will just think about the good questions? We should close. Are there any one of you who would like to say anything in response? If not, I'll hand the mic to the boss.
Add a word on yes. Just a lot of people relate to this, and I just wanted to say that I actually don't see any reason why we couldn't add in the report something that says, while there is debate on whether there is priority to treatment, of course the social determinants are important. While this might be less relevant to you, the particular reader, the health minister, it is something we want to emphasize. In fact, I would even say the document could be an important one if we call for, I don't know, I should interview Ali on the possibility of doing this, but how about if we called for WHO to kind of look more in the direction of some sort of human rights to the most important social determinants, which has the hardest evidence about major impact on the most basic aspects of health. Maybe there should be a universal right to that should be legislated.
We can draft it, right? Okay.
Now, I think one thing that we can do, because WHO has been working on the area of social determinants, is we can circulate a short document that was sort of the best of from the Commission on Social Determinants of Health, outlining policy options in the various thematic areas. And I think, and universal coverage is one of 8 or 9 areas. So that may at least provide some insight on the types of policy options that were considered as most promising, which would be not addressed in depth in these guidelines.
Yeah, I just want to say that this is just, it's not the only guideline to universal health coverage. There are many questions about how to implement universal health coverage, and this is about the fairness question. And so R4D is doing a lot on provider payment mechanisms, on the market mechanisms, etc. So what I want to do is I want, or what, I will say I want, but I hope WHO wants it as well, is a specific focus on this, and to make it clear and simple and realistic, but to just focus on this, and then and then give value to the others by giving them their own guidelines. Because the one thing I have learned is you cannot do too many things. You shouldn't do too many things with one instrument. It dilutes your focus. So this I think really needs a specific focus. Let's not put a lot of caveats and framing around it. Let's just say this is about fairness.
Okay, so just a couple of closing words. Oh, we have one. Yes, please, Gita.
I'm not going to make any comments about the social determinants of health in whichever way. I mean, I don't think sort of putting a little caveat around it somewhere is a terribly useful way of addressing the issue. If we're going to address it, we should simply say, we are not in these guidelines going to speak about the social determinants of health. Not sort of put a thing, say, we think it's important, however, but, et cetera, et cetera. I think that's actually insulting to the social determinants of health, and we should just leave it alone. But I do want to say something about a different issue which I mean, is there a fairness question that is involved in the issues around sustainability of the paths that are chosen? That is there a fairness question? You start going off in one direction, and then because of what happens on the path in that direction, you actually have closed off a whole lot of options that would be much fairer. And I think the question of the public-private choices, which typically these fairness questions avoid, but which on the ground end up being the critical fairness questions that one has to address. What does one do when one says public-private partnership and you bring in the private trust hospital that takes over the government municipal hospital, which was serving the people in the local community, and then makes it out of reach for most of them because of the way in which it operates? What have you done to fairness in that context? And it seems to me that somewhere we need to, in this context, specifically as a question of fairness, address some of these questions. What happens with the public-private is a critical question, and that I think, people threw off a few issues around the importance of a regulatory architecture. Everybody nodded and said, yes, right. But, do we need to say a bit more about that? If you're going to leave it as the path is open, what is it that, by way of guidelines, you would say about the nature of that path? Similarly, populist approaches to the provision of care, and which may end you up in places and directions which aren't terribly fair in the end, because they end up gobbling so much resources that you can't do anything. And yet, they are meeting people's preferences, everybody's happy with them, they are even equitable in some sense because they're getting to the poor things that they wouldn't get otherwise. I do think that we need to tackle some of these, but they're not sort of these, I'm neither a philosopher, and as I already said right at the beginning, I'm a bad economist. So you put all of that together, and much as I've enjoyed the discussions of these 2 days, to me, on the ground, these are some real issues around fairness that I would hope that the guidelines could address.
Any others? So first of all, a couple of thank yous, and then a concluding word. Is Francesca still here? Not. No, probably not. Okay, so we've already said that without Francesca, this would have run to the ground very early. She's a pro at this and does it seemingly effortlessly, but it took a huge amount of effort, so we'll all thank her later. Thank you for the applause. Thank you, Maynard, for keeping the time, and I'd like to thank our WHO members and liaisons and den mothers, if I may use that word again. For us, it's an opportunity to serve in this way, and the chance to engage the work that we do as academics with the very important role that WHO plays, especially in the developing world, in offering standards and guidance and sometimes vision. It's a great opportunity, and we're personally in your debt, both Tessa and Ritu, others we work with, and we appreciate it very, very much. I wanted to end on a happy note. We've talked about problems and distinctions that must be made. It's what philosophers always like to do. We shouldn't lose sight of the vision that's involved here. Gita, you talked about closing off roads, that sometimes you can start down a road with great enthusiasm, and it turns out that it actually doesn't come to much, and now you can't do anything else that's better. I have to say, around WHO, there are those who think that the Health for All movement was a bit like that. There was tremendous enthusiasm for it, born of some of the same sentiments that we've heard here, but it wasn't adequately conceptualized. It was sort of foisted off as a vision, but didn't have enough detailed substance, and so nothing really happened, and it kind of faded away and became a bunch of slogans, and eventually was sort of disowned by people who you might have thought would be its champions. And when that happened, there were many programs that rushed in to take the center stage, and some of them were very important and successful, but that big, big vision that everybody in the world would somehow partake of the benefits of modern healthcare and modern medicine and science, that sort of faded. Until now, just now. UHC came apparently out of nowhere. It was so sudden, and it was so utopian, just a couple of years before it became a big wave. And now it's taken with great, great seriousness. Tessa mentioned that we're just one task force. We're not one of the most important, we're one of the smaller ones. There's one task force meeting now in Bangkok. What are they called? The ones meeting in Bangkok right now? It's on. Okay, well, there's one of the others. I've forgotten which title they have. We actually tried to merge the two, but they couldn't get out of their hotel. Couldn't get out of their hotel contracts. But there are many others too. So it's a big, big array of people who are expert in various fields, all trying to put this thing together, so that this time would have enough substance and the problems would be thought through in advance. And you could offer to the developing countries, which, as I understand it, have come to by the dozen to WHO following World Health Report 2010, saying, sounds good to us, show us how to do it. And we can, putting all our thoughts together, actually offer something that might make it more likely to happen. And if you'd gone back 10 years and asked, is this going to happen in our lifetime, they would have looked at you funny. But now the answer is, yes, it might actually happen, which is quite a wonderful thing. So we can all take pleasure in that, and we'll thank you very much for your contributions.